The clinician to tell us what he can do with all those very nice and helpful classification, and invite Beat Gloor to come and to tell us all about it.
Yeah, dear Chairman and dear organizers, many thanks for the invitation. It's a pleasure to be here, and it's a difficult task to tell whether we can wait or whether we should treat. But the aim is obvious. We want to resect the ones that need resection, and we want to omit unnecessary resections, of course. So I will guide you through some figures that are out there, and you will see they are just controversial. It's not clear. So this was the cystic lesion in the past. 4 tools, some tools, clearly defined what we can do with it. But that's about what we have today. So it's much more complicated. We have to know much more about the different things. So this is somehow the summary of what the 2 previous speakers gave you. We have the serous, the mucinous, the mucinous cystic neoplasm, and the IPMN. So for the serous, the question in the title of my talk is already given, so we can wait. We don't even have to watch, we can just wait, because these are benign. The mucinous cystic neoplasm we heard, if we find it, and it's a fit patient, I can also give you the answer. We're going to do surgery. But here the discussion starts, the IPMNs. And we also heard, and I will show you this, main duct and mixed type is mostly an indication for surgery in a fit patient. So what remains, really the questions, the patients we have to discuss, if we are able to diagnose them properly, are the side branch IPMNs. And this will be the main part of my talk. So this is the problem. We actually don't know the growth and progression into malignancy. We know it happens, but we don't know whether it happens always. We don't know how fast it happens. This comes to the biological behavior, and we have heard already quite nicely, there are subgroups, there are different types, and they behave differently. So the more we know about the cystic lesions, the better we can answer the question whether we should wait or resect. Unfortunately, it's not as clear-cut as in this sketch for either good or no good, but we have made some progress. It started basically in 2006, the Sendai Guidelines. They were focused primarily on the size of the disease, or on the cyst, and it was seen that many of the branch-duct IPMNs have less than high-grade dysplasia. So we could wait. Then in 2012, with more data being available, with more experience, the focus was more on some, as they were called, high-risk features and worrisome features. And these are the solid component, the duct dilation, and the mural nodule. And as we've heard in the previous talk, we have the EOS data that helps us to find the mural nodule, to puncture it, and then to analyze. So the 2012 guidelines are basically what we base on our decisions on. But I will show you that there are exceptions to the rule. So first, the figures. They are somehow different than what you have already seen in the previous talks. So they are based on about 20 publications with 3,500 patients. The risk of malignancy for main duct IPMN was as high as 60%, with a range from 36 to 100. For the branch duct IPMN, it was still every 4th was malignant, a lot higher than what we usually think or see, but the range again tremendously varying from 6 to 46. And also this figure came up in this guideline paper, the yearly rate of new onset malignant. So there is some risk. We have to treat these. We cannot just say operate on the main duct and do watchful waiting on the branch duct. This is not as easy. So just the figures that you have already seen, if you have such a CT scan, you can actually go to the OR if the patient is fit enough. You don't need any other testing. For the mixed type as well, this would be a left pancreatic resection. And I will show you that this is also a very safe intervention. But here, that's the question. Several side branches, when, first of all, resect or not, but if you resect, where to stop? Maybe you end up here in a total pancreatectomy. And that's, of course, we don't want to do if it's a benign lesion. So this is an important paper from recently published in Annals of Surgery 2014. It's a series of patients operated between 2004 and 12, 512 patients, and it's all about branch ducts IPMN. So there were 233 branch duct IPMNs operated upon. This is the histology. And now the next slide, I will show you more data about this group of the 233 branch duct IPMNs. So of these 148, 64% were so-called Sendai negative branch duct IPMNs. So these were 148 surgeries outside of the guidelines. But what they found is 26% high-grade dysplasia or invasive cancer. So we can argue the guidelines are much too restrictive. If they would not have operated on these, they would have missed 26% out of 184 patients with a high-grade dysplasia or even a cancer. And then another very important aspect of this paper is if we're going to say we have different entities, the main duct and the branch duct, but then we realize, or this is the first data out there, that the classification between branch duct and main duct maybe is wrong. So they have almost 30% of branch duct IPMN in the imaging studies were in fact with main duct involvement, so being mixed type. And we have heard these, they exhibit a much larger risk of malignancy. So what is the price of this surgery? This is the morbidity and mortality of the same paper. So they had 13 patients dead, so 2.5% of the 500 patients. If you look at these 13, 8 were actually already cancer patients. And the mortality only arose after the pancreatic has resection, pancreatic duodenectomy, or total pancreatic resection. There was no fatal course in patients with a left pancreatic resection or middle segmental resection. But there is a risk of surgery. This is obvious. The conclusion of the authors was we need a more liberal indication for surgery in fit patients. So this would be a trend away from watchful waiting, more to resection. But there are other surgeons who see this same situation differently. This is a comment on this paper, again in Annals of Surgery, by the team in the Memorial Sloan Kettering Cancer Center. They say it's not harmless just to be more liberal to resect these. They came with their own data. So this is Memorial Sloan Kettering Cancer Center data, 280 resected, and they have a much lower rate of Sendai negative resections, but they resected outside the guidelines. They found in 5 of the 35, so it's much lower number, but they also find some high-grade dysplasia and no invasive cancer, and they compared the figure with a cancer in Sendai positive lesions. Sendai positive meaning mural nodules, dilated duct, and so on. So now the scope is different. These are, again, in the paper in Annals of Surgery 2014, there were 529 Sendai negative lesions that were not operated upon. They were primarily watchful waiting. in a follow-up, rather short, 20 months, you see the size, 3 millimeter to almost 3 centimeter. In only 22 of these 529, they went on to surgery. So they stopped the watchful waiting strategy and went to surgery because of the growth of the lesion or an increase in markers they analyzed. What did they find in these 22? They had 4 cancers not associated with IPMN. They had non-invasive in 10 and 8 benign lesions. So in the end, they had 8 resections out of 529 that were not necessary, but they found 14 that were really necessary to resect. What was their mortality and morbidity? They had morbidity 30%. They have a 2% mortality rate in their pancreatic surgery team. So they say if they would have resected all these, they would have had 11 patients dead for prophylactic surgery without a malignant feature. So they say watchful waiting is preferred. So we have heard about the histologic subtypes, and this is the corresponding figures. You have seen this, so I can skip. We know now this is the gastric type in the side branch, and we know this is the bad one. So the next question is, what is there more data than what I have just shown you on this other slide? This is 14 studies, 1,600 patients, and the summary is again the same. The pancreatic biliary is much more prone to have cancer, and it depends on the pathological subtypes. So this will be the question if we can know this preoperatively. So the marker, again, this slide you have already seen, so I can go fast. But I look at it a little bit from an other angle. We have heard dysplasia and malignancy is different. But what we're interested in is knowing the patient with high-grade dysplasia. The prognosis is, of course, much better if we can operate on these, but we cannot distinguish. So these are not helpful to discriminate. So now to add some to the confusion, the AHA came up with guidelines by their own very recently in 2015. They had a technical review and they looked at 305 references, so really an in-depth analysis. And to summarize it, the recommendation is much more defensive than what has been published in the Sendai 2012 guidelines. The guideline says that only patients with more than one high-risk feature should undergo further diagnosis, endoscopic ultrasound, whereas the Sendai say with one high-risk feature, go to surgery. So there is quite a discrepancy. And why is this? If you read the guidelines carefully, you realize that the figures the guidelines are based on are in the AHA totally different. So the baseline risk of malignancy is estimated to be 0.25%. So they say, and they acknowledge, if there is mural nodule, the risk increases, they say, by 7.73-fold. So if you multiply this by 8, you end up with 2% risk of malignancy in a cystic lesion, in a branch-line cystic lesion. And you have heard the figures of the morbidity. So here still the disease is less dangerous than the surgeon. So in the end, they came up with 10 recommendations, but they are all conditional recommendations and a very low quality of evidence. And the surgeons that were authors in the Sendai 2012 guidelines came up with the following comment. They said the evidence is not here, it's controversial, not helpful, and lack of evidence. So we clinicians, we have guidelines by two societies, but they are really not corresponding. So I can skip, I prepared a clinical case, maybe we can discuss this later on. So the next question I would briefly talk about is, once we have resected and we have not resected the entire pancreas, what do we do with the patients? What is the, again, watchful waiting, or when do we have to go back to surgery and resect further on? This is a paper from Surgery 2015, 134 resected mucinous cystic lesions between 2002 and 2012. The follow-up was 42 months. The 2/3 IPMN, 1/3 mucinous cystic neoplasms. So not surprisingly, for the mucinous, there is 0 recurrence rate over 3 years. So we know if it is proven mucinous cystic that has been resected, we can tell the patient, you're cured, you don't need to have further follow-up on a regular schedule. But for the IPMN, it's a little bit different, and that brings me back to the initial question. So it's not early, the recurrence. The first year is no recurrence, but then it increases. And what were the risk factors for the recurrence? A positive resection margin at the first surgery, a cyst that was larger than 3 centimeters, or high-grade dysplasia seen on the histology. So this is what the authors came up with, the recommendation, watchful waiting or resect for IPMN. If it's low grade and positive margin, it's yearly, it's negative, and basically as a surgeon experienced in pancreatic surgery, it's rare, it's very rare you have positive margins in the cystic lesions. Usually you can resect them in what we would say in a cancer in an R0 situation. But if you end up with a high-grade lesion with positive margin, you have to go further back to the OR. But for all the other, it's all 3 years, all 2 years, or 2 years. This is a recommendation based on these 134 patients, but it's more or less the only data that we have to guide us. So now, just short final remark, the risk of the disease versus the risk of treatment. Surgery is not harmless. This is a study just recently published, 2016, a German multi-center randomized control trial. The question in this trial is not important for what I'm telling you now about the cystic lesions, but it shows us what is daily practice in pancreatic surgery in this example in Germany. 440 patients treated quite recently, from 2011 to 2012, in 14 high-volume academic centers for pancreatic surgery. And we know the data is quite clear. If you perform pancreatic surgery more often, your results are better. So what did they find? They looked at fistula, 20%. This is not surprising. This was not more nor less what we knew. But this was surprising. There was a mortality of 6% in high-volume academic centers. And the multivariate variable analysis showed that its soft pancreatic texture is an independent risk factor for the pancreatic fistula. So what does tell us in terms of watchful waiting or resection in cystic lesion? The problem is the branch duct IPMN, they have most often a soft pancreatic texture. So the most dangerous lesion in the end, taking all the data together, is the branch duct IPM in the uncinate process. Because I have said there are hardly any fatalities after left pancreatic resection. If patients die after pancreatic surgery, it's after pancreatic head resection. So if you have the combination of a soft pancreatic texture, a non-dilated duct as you have it in branch duct IPMN, this is the patient at risk. So maybe we are prone to wait a little longer in this, in such a lesion, as compared, for example, to a lesion that is in the pancreatic tail. So I come to the conclusion. Well, the challenge are the small cysts. But we know there is no need to hurry and immediately perform surgery. So there is time to do a second investigation, to wait even some months, half a year. If we manage by molecular analysis, by endoscopic ultrasound, to identify it as something else than branch duct IPMN, then the decision is easy. For the branch duct, it remains difficult. The EOS, together with what we have heard in the second talk, is what helps us most. And for me as a surgeon doing pancreatic surgery on a regular basis, for me, I still stick to the Sendai Guidelines. The HA guidelines are a little bit basing on another patient population. But in the end, we adapt the recommendation according to the subtype, if we know it, according to the localization of the cyst, of course, the general condition of the patient, and then the surgical expertise. Thank you for the privilege of the floor.